Introduco l'ultimo relatore di questa sessione, che è il dottor Myres, che è responsabile del programma Choosing Wisely del paese di Galles. È un medico di base, ma è vicepresidente dell'Accademia del Medical Royal College ed è presidente del Royal College of General Practitioners del suo paese. Per 30 anni ha lavorato come medico di base nel nord-est del paese di Galles, dove si è occupato di medicina clinica, ma anche di insegnamento, di gestione della qualità e della ricerca e di gestione della salute pubblica. Lo ringrazio molto di essersi spostato dal paese di Galles per venire a parlarci della sua esperienza.
Buongiorno, good afternoon, Orada. Wales is not the centre of the world, but it is slightly better than Italy at rugby. I'm a family practitioner. When the patient sits down in front of me, that person is the most important in the world at that particular moment in time. And I want to ensure that I meet their needs rather than my needs, and I want to ensure that what we do for them is appropriate to them. But if I spend half an hour with that one person, that's less time to spend with the next person. If I refer everybody with chest pain up to the cardiology clinic, the next person's going to have to wait longer. So I actually have to think not just about that person in front of me, but also the other 1,499 people that I have some responsibility for as a family practitioner in Wales. And then somebody pointed out, actually, if I spent a bit more time telling them not to smoke, they wouldn't have their chest pain, and I wouldn't have to worry about sending them up to cardiology anyway. So then I had to think of a whole population approach. And my role is, as a primary care doctor working in public health, is to try to balance between getting the very personalised individual care, but also thinking how we provide care to whole populations and communities. And that's really where the concept in Wales that I'm going to tell you about of prudent healthcare comes from. A recognition that the current system in Wales is not going to survive. We can't sustain because there are limitations. So what I'd like to tell you about, I'm not going to talk to you about Choose Wisely. That's actually not my remit today. My remit is to tell you about a whole system approach to how we can continue to make sure that we can provide care to as many people in our communities as is possible, but actually use the resources that are already in the communities, not just the medical resources. So our founding father in Wales was Bevan. He was a politician who came from mining communities in the 1940s, and he set up the National Health Service in the UK. And we're very proud of him in Wales. And we still hold to these principles in Wales as to be our founding principles, that everybody in Wales should have access to care, and it should be based on their needs, not on their ability to pay or how loudly they shout. That it's comprehensive, so we provide care right across in a holistic way. That it's free at the point of delivery, so anybody can access that care, and at that moment in time, they do not have to pay anything up. That we value them as much as we value ourselves as clinicians. We need to ensure that all sorts of policies, so things about transport, things about environment, employment policies, impact on health. So we need to ensure that we think about the health implications of all our policies. We want to make sure that we don't provide great care, but then make it not available because nobody can get there because they're accused to get there. We want to ensure that the care that we provide is high quality and high quality for all, and that actually the harm that's done to patients is minimized. And we want to make sure that we as clinicians and as a service continually improve. But actually the reality is quite different. At the moment, the requirement for our services is actually more than what we can provide. People go to different specialists for different bits of their care, and so they don't see their carers joined up. They don't see the same clinician each time because they may see a different junior doctor or a different consultant or a different GP each time or a different nurse. That there is no join-up between healthcare and social care because both those are essential for the well-being of the patient. And here at risk, I'm going to suddenly create 300 enemies. We have too much concentration on specialists and not enough on generalists. We don't use e-health enough. We don't use electronic health. We still rely too much on face-to-face consultations. There are still marked inequalities depending on where you live and where you're born or where you work in Wales. So a commission was set up by the Welsh Government, independent of Welsh Government, to start looking at that. And they recognised that funding was getting worse in Wales than the rest of the UK. They recognised that the demands of patients with living longer, with more complex conditions, having more complex treatments, was putting pressures on that funding gap. And at the same time, we had to make savings. Look at the variation of life expectancy across different parts of Wales. We decided in Wales that's not acceptable. Why should it be that some people living in some parts of Wales are almost living 30 or 40% more than other parts of Wales? We have a term called the inverse care law. What we found actually was those people in the poorest parts with the most needs had the fewest doctors. So that actually the provision of care was inversely proportionate to the need for that care. So what are our challenges? People living longer. We know that we can prevent more disease, and we're not preventing it. We have social inequality, that some people get a lot and other people don't get very much at all. We've got rising costs, and our workforce, because of the pressures that they're working under, are becoming demotivated. Right across the healthcare system, there's a demotivation in the workforce. We've got a big challenge, because actually our responsibility is look for people from the cradle to the grave, right across through those life courses that you see up there. And actually where we spend all our money and resources is actually at the end. Between treatment and death, that's where we spend the most of our money. That's where we spend most of our time. And we don't seem to be concentrating at the bottom end, making sure that our children have born into healthy lives. They know how to look after themselves. They know how to care for themselves. They know how to deal with stress. They know how to take their medications, etc. So prudent healthcare. And prudence, it's a difficult word to translate, but it's about making most use of your resources, not just your financial resources, your estate, your buildings, and also the people you have working for them. Should be delivered in a safe way, in a cautious way. Let's wait, let's stand back sometimes and not rush in with new treatments. We need to think very carefully. We need to plan our care with our patients. And we need to be careful with our money, that we spend our money in the most appropriate way, where we get best value for that money. And we want to make sure that we concentrate on outcomes. So that's not the outcome at the end of a piece of surgery. How are they feeling 6 months later? Are they any better for 6 months later? And it was really good to see that good slide on interventions of back pain, which actually showed that the conservative treatment, when you carried on for a year, was actually showed equal effects to those with more intensive intervention. So can we afford occasionally to wait? So what are the objectives? The objectives is that we want to provide healthcare that actually meets the needs of the individuals and their particular circumstances, not what we think is necessarily right for them, but what are their priorities. So the old lady whose most important thing is, I want to walk my dog and I want to go and get my newspaper, not to have complicated interventions, endarterectomies or whatever. Those are the sort of discussions that we need to be having. We want to change our system in Wales that is currently focused on meeting the needs of hospitals and family practitioners, but actually meets the needs of the patients that it serves. And that's going to require quite a lot of remodeling and quite a lot of change in culture from people like myself, and I guess my colleagues like you working in hospitals, and also from patients themselves who expect to be told what is good for them. So we refer to this term co-production. Co-production means we are creating health with an individual, not to them. They're not doing it on their own. It's a shared experience, and we're equally contributing. We want to make sure that we actually deal with those with the greatest need first. It's very tempting to deal with the pushy people, the people who come through the door first, the people who shout the loudest. They're the people who we tend to treat first. So let's try and identify those people who most need that care. Let's only do what they need. Sometimes it's very tempting, and we've obviously talked a lot about this morning, to do extra tests, to give them extra drugs, to give them extra medication, to send them for extra treatments. Actually, first of all, let's just concentrate on doing what they actually need. Let's make sure that we don't harm them, because so many of our treatments do cause harm. And let's make sure that people in different parts of Wales actually get the same treatment. One of the things that I do is look at the variation in outcomes and processes across various family practices across Wales, and there is a huge variation. Now, we don't make a judgment on that. There may be very good reasons for it. But let's start to have conversations with our patients and with the clinicians. Why is it that somebody in North Wales will actually have their blood pressure controlled much better than in South Wales? So the first principle is we will work with our public and we will work with our patients, and we will involve patients in the decisions about their bodies, their families, their communities. And we will make sure they get the care that they want, not that we think they should have. We will also work with communities. We will look, what can the community provide? It doesn't have to be the health service. What does the community provide? What do the fire service provide? The rescue service? What do the leisure centres provide? What do the old persons clubs provide? All this can improve people's health. It doesn't have to come from healthcare. We will care for the people with the most need first. So we need to identify those who are the most ill, the most in need. And we need to make sure that we put our staff, our clinics, our hospitals, where the needs are most, and not where it's most convenient for other services. We will only do what is needed. We won't harm them. We won't do extra, but equally important, we won't undertreat them. And we need to make sure that the treatments that we use are proven, that they do actually do what we want them to do. And we want to make sure that patients understand that actually our treatments can cause damage. And sometimes it's only the patient who can decide whether that damage is worth the risk, it's worth doing that. And lastly, we want to make sure that everybody in different parts of Wales has access to the same treatment and, more importantly, outcomes, that the same outcomes. And we need to examine why there are different outcomes. That means we have to have very good data, and that's quite a problem. We're quite lucky in Wales that we have in primary care, we have a system that extracts data from all the practices. So we've got a wealth of very good public health and intervention data, and increasingly the hospitals are beginning to use the same systems as well. So we've got a real big advantage there. We want to make sure that the best treatment is available to everybody. And patients need to be sure that the treatment they get is high quality treatment, and furthermore that the people providing that treatment are skilled up to do the jobs that they're able to do. We used to have a maxim under these principles: you should only do what only you can do. So you just concentrate on your particular skills. But actually, quite a lot of us in primary care said actually that would make everything very rigid, and sometimes we do need to do things. Sometimes, if I'm visiting a patient at night and they have to go to hospital, I have to ensure that somebody's looking after the cat. Or I might have to ensure that the front door's locked after the person's gone off to hospital, because there's nobody else to do that. So we have to have that little bit of flexibility. So what do patients want? Patients want to know what their choices are. What do I need to decide on? They want to know what are the benefits of this particular treatment and what are the possible harms. And then, how likely is it that I will benefit from it? Or how likely is it that I will come to harm? Is there anything that I can do to help myself? Or is there anything that I can go to other people to help me? Can we go to the pharmacist to get care rather than necessarily coming to doctors? And then, what can I do to support you? I was very struck. I went to see our health minister sometime, and he said, you know what you doctors have got to stop doing? You've got to stop cradling your patients. And I've been really guilty of this. I want patients to love me. So I bring them in and say, what can I do for you? I'll help you. He says, we can't afford that luxury. What you can do is direct them and occasionally hold their hand. But at the end of the day, it's their bodies and their lives, and they have to make those decisions for themselves. So we have to balance, and this is a culture change. And I'm going to be very interested to watch the journey that you're just standing on, is how far do we concentrate on what the citizen needs, and how far do we concentrate on what the system needs? Because we know what's efficient in the system. We know what we're good at. So we have to find a balancing act between those two. We have to consider all these things in those boxes that actually make up how a patient feels. And that's not just what's going on in their liver. That's not just what's going on in their big toe. Or that's not just the fact that they've got depression. We have to start looking at all the aspects in their lives. Where are they living? What's their work? What's their community support? What's happened in their lives in their past? What false beliefs did they come to because this is what happened to my grandmother, or this is what happened to my husband? And another place where I'm going to lose all your friendship, and that's sad, but I think it's necessary, is actually, if we have stronger primary care, there is very good evidence internationally, both in the third world and in the Western world, that actually having generalists in hospitals and out in the community leads to better health outcomes overall. So your overall population health is better if we have a greater shift towards having generalists. So that we need to strengthen up our primary care systems, and that's one of the things that's happening in Wales at the moment. I daren't read out the bottom thing. So, what is primary care going to do? It's going to provide care over a long period of time. It's going to remain the main point of contact, and it's going to look at the whole person. It's going to continue to look at the whole person, not the disease that they present with. And it's going to try and coordinate the care, so the care provided by specialists, the care provided by families, the care provided by social workers, even the care provided by the church, by priests, if necessary. And we need to make sure that it covers all. So what we're going to balance is the population health, the personal health, and the community health. And that's what Wales is going to focus on over the next few years, is how do we try and balance all those? Personal health, which is the care that most of us provide, the population health, which is part of the state of the nation, if you like. It's about health prevention, it's about the services, it's about nutrition, and how do we help community health, which is the strength of the support in the community. Grazie.